Hi guys, so now it's time to do a deep dive on a heavy hitter, okay? Heavy hitter being that pneumothorax, okay? That pneumothorax. We're gonna go through every single different kind of pneumothorax that you can have, okay? But first of all, you need to understand the pathophysiology of a pneumothorax is the collapsing of the lung, okay? The collapsing of the lung, but how is it collapsing, okay? What's causing the collapse? All right, so what's causing that collapse is air that collects and builds up in that pleural cavity. Okay, your pleural cavity is that lining in between the wall, okay, the wall and your lung is that very skinny little lining, okay? That's your pleura or your pleural cavity. And when air collects in that cavity, it applies pressure. Okay, it applies pressure to the lung, which then eventually causes it to collapse. Okay, the air leaks. Okay, air leaks from the lung into the parietal and visceral pleura in the chest. That's where the air comes from. The air then accumulates and creates that pressure in that pleural cavity onto that lung and causes it to collapse. So that's what it is. It is a life-threatening condition. Okay, it can be a life-threatening condition and it requires immediate attention. All right, the negative pressure in that pleural space is required to maintain lung inflation for the lungs to inflate and deflate. Okay, so when that pleura is breached, air then enters that pleural space. Okay, and then the lung starts to get smaller. Okay, it starts to get smaller and it's termed as collapsing. It collapses. And then the oxygen pressure then decreases. So there are two ways that the air can enter that pleural space, and that's either by trauma to the chest wall or by a rupture of that visceral pleura, okay, where the air leaks it leaks from the lung into that cavity. All right. So there is a thing called traumatic pneumothorax. And this comes from a blunt force trauma or penetrating trauma, such as like a rib fracture, a stab, or a gunshot wound. And the trauma to the chest creates a one-way valve into that pleural space. Air can flow in, but it can't really flow out as freely, okay? So you get stabbed, you get shot, okay, in the chest or something, okay? There's a subdivision underneath that traumatic pneumothorax, which is called an open pneumothorax. This is a form of a traumatic pneumothorax where the wound in the chest wall is large enough to where air can pass in freely. It'll create this sucking sound, okay? It's also called or referred to as a sucking chest wound because air from the outside starts to rush in and insert that open cavity, okay? You also have the iatrogenic pneumothorax. This is also a type of traumatic pneumothorax. And this happens because of either a diagnostic or a therapeutic procedure. So like a thoracentesis, a pleural biopsy, a central line placement, mechanical ventilation, or a thoracoscopy. So these are things that are man-made or that are caused by the force of man, okay? So you have a primary spontaneous pneumothorax as well. This occurs automatically without any contributing conditions, okay? And then you have a secondary spontaneous pneumothorax, and this is from underlying pulmonary diseases, okay? So pathophysiology, again, lung collapse, okay? But be mindful or be knowledgeable of what is causing that collapse, okay? How is it occurring, okay? Next thing I want you to be mindful of are risk factors, okay? Smoking, whether it be tobacco, cannabis, okay? Smoking, period, okay, is a risk factor. Being, having a genetic predisposition, okay? Also having a family history of pneumothorax. Even high altitudes and high atmospheric pressure can put pressure or cause pressure, okay, on your lungs to cause them to collapse, okay? Mountain climbing to very, very high altitudes, okay, can also cause some pressure on the lungs, All right, so pressure, pneumothorax stems from pressure, regardless of how the pressure is coming. All right, we're also going to touch on some more tension or traumatic pneumothorax in just a moment. Okay, but what does your health look like? How is this going to impact someone's health overall? I always touch on the aging adult. Okay, we always have to consider our aging adult. We know their normal changes is reduce, decrease. Everything decreases as we age. But decreased elasticity or reduced elasticity in the lungs, we know that already happens in the respiratory tract, which then leads to reduced oxygen delivery. Okay, a lower blood oxygen saturation can and will most likely occur. And your older population, their normal O2 sats are probably at a 93, 94, which is normal for them and can be considered ideal. But for somebody younger, okay, we want to see 94 to 96. We really want to see 100, but we will be cool with a 96, okay? But your older clients, they require a larger energy expenditure, okay, due to their rigid chest wall, all right, decreased lung capacity, and also the reduced rib cage volume because their lungs are not as elastic. They're not filling up completely and relaxing all the way. Okay, so you always want to have them in mind. Okay, clinical presentation and your manifestations. What are you going to see? Okay, so for pneumothorax, it can include chest pain, shortness of breath, dyspnea. Okay, your tension pneumothorax is going to have some severe hypotension. Okay, some presence of distended neck veins. Okay, that jugular vein distension. Okay, that's also going to be very prominent for someone with a tension pneumothorax. Okay, we'll get into like your tracheal deviations and all of that in just a second. But for pneumothorax in general, they're also going to have asymmetrical lung expansion. Okay, so if I have a right pneumothorax, when I breathe, okay, but the left side is only going to rise and fall. The right side is not going to expand, it's collapsed. So when I breathe, this side of my chest is going to rise and fall. This one is going to stay the same. Okay. Also, whichever side has the pneumothorax, they're also going to have some decreased or absent breath sounds on that side. Okay. They're also going to be tachypnic and tachycardic. Okay. Hypoxic. All right. We as LVNs do not percuss. But if percussion is done by like the RN, they will have decreased tactile fremitus. Okay, that vibration is going to be decreased. Okay, again, because the lung is collapsed. Okay, now for your tension pneumothorax, I'll get into some of your manifestations for that as well. It is going to be some severe pleuritic chest pain. Okay, it'll often radiate to the shoulders. Okay, they will tell you, I have shortness of breath. All right. You will also see, of course, still the increased heart rate, decreased blood pressure, jugular vein distension. And again, how you test for that or how you assess for that, you have them turn the head and you shine a light on their neck. Okay, you'll see this big vein here pulsating. All right, pulsating. Okay, that's that jugular vein distension. Dyspnea, cyanosis. Okay, check the mucous membranes or the lighter areas on the body. They will have cyanosis. Sharp pain, again, radiating to the back or the shoulders. They will be in acute respiratory failure. I will create a respiratory failure video later as well, and eventually go into cardiac arrest. Okay, they will have tracheal deviation. Okay, I need you to have that verbiage, tracheal deviation, and it will deviate from the affected lung, which will apply pressure. Okay, it will apply pressure to the heart. All right, and result in hypoxemia. All right, so let me give you a picture of this. Okay, so say I got in a car accident. And I was in the passenger side of the car and got struck. Okay, on that passenger side, I had blunt force trauma on this side. So I have a right tension pneumothorax, okay? Right tension pneumothorax. I will also have tracheal deviation, which will cause my trachea, which usually sits here in the center, to deviate to the left, okay? Deviate to the left, all right? Or depending on how hard, okay, how hard I got this hit this way, all right, this lung can eventually kind of push into the trachea and even deviate it to the right, depending on how hard, and it'll be kind of bent, okay? But that's a tracheal deviation, means that it is no longer aligned. It can even deviate to the right, deviate to the left, okay? Just know that it occurs with a tension pneumothorax, okay, from trauma, from pressure, okay? Now, I want to reiterate a little bit more about that trauma. Okay, trauma does not only mean, I know I gave you the example of a motor vehicle accident, but I mentioned as well central line placement, mechanical ventilation, lung biopsy, tracheostomy, bronchoscopy. These are all things using manpower. Okay, manpower. We don't really know a lot of our strengths at times, but us putting that pressure, okay, can put too much pressure or apply too much pressure to cause that lung to collapse. All right. Even scuba diving as well. Those depths of water, okay, that water pressure is very, very high, okay, and it can also cause a tension pneumothorax, okay. So just a quick recap: increased heart rate, decreased blood pressure, okay, jugular vein distension or JVD, dyspnea, cyanosis, pleuritic chest pain, okay, acute respiratory failure, and cardiac arrest, okay? That's your hemodynamic instability that you want to look for, okay, that your patient is going to present with, all right? So now some testing that we're going to do for this. Diagnosis is usually made by chest x-ray, okay? They can also use an ultrasound or a CT scan to, get a better look. But diagnostics is usually done by using a chest x-ray, okay? So your role as the nurse with these patients, if your patient is experiencing a pneumothorax, they can become very anxious and very fearful, especially with the difficulty in breathing, the dyspnea, as well as the pain, okay? It's going to be sharp pain, maybe even stabbing pain, okay? You want to try to have them remain calm, provide reassurance to them, okay? Reassure the client, reassess them, prepare them for management of that pneumothorax. You're going to prep them for a chest tube, because that's what it's going to come down to, the placing of the chest tube. You won't be placing the chest tube, but you can help them. Okay, you can help. You could pass whatever you need to pass them. If they allow or whatever, if you're in there, you can assist. However they will allow you to assist. You can also educate your patient on the procedure, okay, and the necessity of each, of why. Why are they doing a chest tube? Okay, you can provide pain relief. You can provide comfort. Okay, but ultimately the severity of the client's condition will dictate the intervention, what type of intervention is done, okay? Again, pneumothorax is an emergency, and they will require immediate intervention, all right, and probably be admitted to the hospital, okay? So, applying your nursing process when it comes to these patients, recognizing cues, okay? Recognizing your cues, this is your analysis, your data collection. Knowing that a pneumothorax is a life-threatening emergency, your ABCs come first, okay? ABCs, assess the airway, the breathing, the circulation, okay? Once the oxygen and perfusion has been stabilized and maintained, now you can get a history and physicality of the situation. Okay, then you can get diagnostic exams such as the chest x-ray, the ultrasound, the CT, all of that then can be collected. Okay, but your ABCs is first and foremost. All right, next you're gonna analyze your cues, all of the data that you got. What does it mean? Okay, you need to analyze it. All right, diagnose the problem, okay, within your scope. We don't diagnose and give diagnoses, but we have nursing diagnosis, NANDAs, okay, that impaired gas exchange or all of that, right? Then you're also going to you're going to come to terms or realize or know that pneumothorax, it can ultimately cause a significant decrease in the blood pressure. Okay, so early intervention is necessary. Early intervention is necessary. Assess for the manifestations of shock as well. Okay, client breath sounds may be diminished or absent, which we talked about, especially on the side where the lung is collapsed. Okay, and then ongoing breath sound assessment is required while providing care for this client. You're going to need to continuously assess this patient. Okay, analyze the O2 sats and the pain level. Okay, and control that. All right, next is you're prioritizing your hypothesis. Oxygen and perfusion are your priorities. Again, I can't stress it enough. Your oxygen and your perfusion is your priority, especially if they have a pneumothorax. Okay, should be corrected immediately to prevent further complications. Okay, further complications, cardiac arrest. Okay, so you need to assess and intervene immediately. All right, next would be generating your solutions. Okay, work with the care team. Work with the care team to figure out a care plan. Okay. The ultimate goal is to decompress the pneumothorax and re-expand the lung. That's the goal here. Okay. Then you're going to take action. Place the patient in high Fowlers, okay, to promote and enhance that lung expansion. High Fowlers is the position that they need to be seated in while they're in the hospital bed, okay, with a straight spine, okay, 90-degree angle, all right. You also want to assist the client with splinting, okay, cough and deep breathing. Splinting where that, especially because they're going to have a chest tube. You don't want them to cough and the chest tube pop out, all right? So splint, cough, deep breathe, okay? Support that chest and also reduce the comfort. Use a pillow, like a long pillow or two if you got to, okay? You're also going to want to administer analgesics for the pain, oxygen as required, okay? And then evaluate your outcomes. Is it getting better? Is it getting worse? Is it staying the same? All right, but you're going to evaluate the oxygen and the perfusion, okay? An improvement in both should occur with treatment, okay? Their perfusion should be improved, okay? Their oxygenation should be improved. Their vital signs should kind of normalize, all right? That's what you want to see, okay? You want to see them comfortable. Their pain level should be decreased now, okay, when you evaluate these outcomes, okay? That's pretty much it for pneumothorax. Okay, I know this one is a doozy. It can be. So happy studying. Okay, remember your focal points, your goals. Okay, the things that you want to see for your patient.